Unit 20, Meeting Resident Needs, Maintaining and Restoring Mobility. Restorative care refers to nursing interventions that promote the resident's ability to adapt and adjust to living as independently and safely as possible. It's helping the resident attain and maintain the highest level of functioning possible. The reasons for restorative care: it's required by federal and state regulations. It's expected to fulfill the resident's Bill of Rights, and it demonstrates a belief in the dignity and worth of each person and resident. We want them to maintain their independence as much as possible. We do not want them to enable us to perform activities for them that they can be doing on their own or with minimal assistance. So we want to maintain that level of functioning and keep them from having a functional decline. The overview of restorative care: it relates to all aspects of residence care. It stresses preventing further disability. It strengthens what the resident can do rather than focusing on what he or she is unable to do. So we want to focus on what they can do and strengthen that. It's guided by a written care plan developed by the interdisciplinary team. The care plan contains individualized, measurable goals and specific interventions. Those we have discussed in prior units. It's provided to all who have responsibility. It's provided by all who have responsibility for resident care, with the supervision by the nurse. Some facilities utilize restorative aides, which is a CNA with additional training and education to specifically implement restorative care. Other facilities anticipate that all staff provide restorative care. And restorative care occurs 24 hours a day, 7 days a week. Additional rehabilitation. Additional measures may be part of the resident's care plan. The term rehabilitation is sometimes used interchangeably with restoration or restorative care. Rehabilitation is provided by specialized therapy such as speech therapy, physical therapy, or occupational therapy, or nurses. Components of the restorative nursing program include, but are not limited to, range of motion, mobility, including bed or chair mobility, transfer activities, ambulation, and use of splint or braces or prosthesis care, eating or swallowing, bathing, dressing, and grooming, toileting and elimination control, and communication. All of these components we have covered in other units throughout this course. Terminology: specific terms are used to describe assistance given to the resident. Understanding them will help to accurately follow the care plan and communicate with other members of the team. Activities of daily living are basic tasks of everyday life, such as eating, toileting, bathing, dressing, and moving and walking. Self-care deficit: they're unable to perform an ADL without assistance. Task segmentation: it's kind of where we talked about where maybe they can only do certain tasks, like maybe put an arm in their sleeve of the shirt, and then they have to take a little bit of a break, and then they can put the rest of the shirt on, and then they have to take a break before they can put their pants on. So task segmentation is breaking up an activity into smaller steps or subtasks so that the resident can accomplish them. Additional assistance such as verbal or physical aids the resident in accomplishing the small steps and therefore the whole activity. And maybe they have to do task segmentation because they have chronic obstructive pulmonary disease or COPD, where they get really short of breath when they're doing activity. So they have to do it in segments in order to complete the whole activity. Setup is preparing the environment and the equipment and supplies for the resident to be able to perform an activity. Positioning: preparing the resident to perform the activity by placement of body or extremities. If you remember, when we were in lab, we took and we positioned the patient closer to the side of the bed so we could set them up and dangle them. Oversight is staying near the resident, watching the activity being prepared to cue or otherwise help them. A cue: it's showing or prompting the resident to perform the activity. Cueing may be verbal or nonverbal or physical. Okay? So maybe cueing is, hey, remember to take a bite of your meatloaf, or do you want a drink of your water, or can you put the brush in your mouth and now brush your teeth. Or we might have to do guided maneuvering, which is touching or moving the resident's limbs through steps of the desired activity, such as hand over hand technique is an example, where maybe they're eating and they're not getting the fork up to their mouth, so we have to take our hand, put it over their hand, and help guide it up to their mouth. Coaching is encouraging the resident to perform the activity, providing compliments, even with the small successes, and encouragement and praise. Pacing, it allows time for a task to be completed by the resident and for the resident without making the resident feel rushed. So we want to make sure that we have time in order to help them and not make them feel rushed. Your responsibilities for restorative care include being skilled, competent, and consistent in providing care, following and contributing to the resident's care plan, keeping accurate records, demonstrating an attitude that regaining, maintaining, and improving function is desirable and possible for the resident, so we want to be very encouraging and very positive, and demonstrating an attitude of respect for the resident. Complications in inactivity, physical changes. Inactivity and immobility have serious physical consequences. If the resident stays in any position too long, whether sitting or lying, adverse body changes are likely. Have you ever just lied there in bed and when you woke up, your arm was completely asleep, or it was really difficult and painful to move it? That can occur, but it can be even more extreme with the residents that do not get repositioned. Restorative care and inadequate activity support is physical and emotional well-being. Inactivity leads to further decline, and good care does not mean doing everything for the resident, but empowering the resident to do what is possible. Physical consequences of inactivity continued. The musculoskeletal system, your muscles weaken and waste away, basically. That is what atrophy is. The joints tighten, producing contractures. So if they get contractured, you might not be able to straighten out the arm because of the contractures and the shortening of the muscles. The bones lose calcium and other materials that keep them hard and strong if they do not bear weight, resulting in osteoporosis and increased frequency of fractures or breaks in the bone. The integumentary system, especially the skin, pressure from not changing position deprives the tissue of oxygen and nutrition, and as you well know, it can lead to skin breakdown or ulcers. The genital urinary system, minerals are lost from the bones. It can precipitate to form kidney or bladder stones, which are very, very painful. Inactivity is associated with difficulty urinating and incontinence. The GI system, the inactivity is associated with slower bowel function and constipation. Eating in more than upright position makes aspiration more likely, because if they're in more upright position, the food is more likely or fluid to go down the wrong pipe, which would be into the trachea, which would cause the aspiration. The respiratory system, breathing is more shallow, fluids and secretions accumulate. Pneumonia is an infection of the lung tissue, and it is more likely. The cardiovascular system, the ability of the heart muscle to adapt to increased demand is impaired by inactivity. The circulation is slowed. The lack of muscle movement and pressure from lack of change contribute to the formation of blood clots. So we want to, again, make sure that they are up and moving and doing as much as they can for themselves so we don't end up with these physical consequences. Pressure ulcers. The skin breakdown, also known as decubitus ulcer or bed sores. The risk factors for a pressure ulcer include anything that disrupts the skin integrity and or diminishes oxygen and nutrition to the skin and underlying tissues. When the resident has limited ability to change position in the bed or chair, they're at more risk. If they are bedbound, if they're susceptible to friction and shear damage to the skin and underlying tissue during repositioning, that's why it's very important to make sure that we're lifting the resident instead of sliding them on the sheet or the draw sheet. We want to be lifting them so we're not causing that friction. If they're incontinent of bowel or bladder, they have other skin moisture, such as between the skin folds, in the skin folds of the abdomen if they're obese, the skin folds of the breasts of females, the armpits, We want to make sure that they remain dry whenever we're repositioning them. Check those areas also. If they have medical conditions that interfere with good blood supply or circulation, particularly to the extremities, if they have poor nutrition or poor fluid intake, and if they have movement limited with restraints. And restraints is a whole nother subject. We have to do special checks with them and check on them more frequently and document a lot more. Signs of tissue breakdown or pressure ulcer formation. Any signs of impaired skin integrity, you want to promptly report it to the nurse. Check the bony prominences, the areas where the bone is close to the skin, such as the elbow, knee, ankle, heel, spine, sacrum, or coccyx, the hip, and check skin folds. Observe for changes in skin color, such as redness or dryness, particularly when it does not disappear within 30 minutes after the pressure is removed. Other early warning signs are warmth and tenderness at the site, or the resident reporting a burning sensation. Check for broken skin or formation of blister-like lesions. This is a sign of increased damage. Damage below the skin surface occurs before the skin actually breaks. And more advanced damage is shown when a crater forms after deeper tissue is destroyed. Damage may extend into the muscles, to the bones, and to the joints. And you've seen some videos on that to where you've seen how severe the pressure ulcers can get. We need to make sure that we are repositioning those residents on a regular basis. If they're bed bound or they have troubles moving in bed, we need to be repositioning them on a regular basis. Prevention. An ounce of prevention is worth a pound of cure. It is true in the management of pressure ulcers. It is much more time consuming and costly to heal a pressure ulcer than to prevent one. And if the resident develops a pressure ulcer in the facility is responsible for paying for that treatment until it's cured. Insurances will not reimburse for impaired skin integrity that occurs in facilities because they can be prevented. So again, an ounce of prevention is worth a pound of cure. Prevent functional decline and addressing the potential causes for injury. Encourage the resident's mobility in bed or chair. The resident changes bed position using devices such as a trapeze or assisting rail as needed. And we talked about the rails. We've also talked about trapeze, the little triangle that's above the bed that they can grab a hold of and pull themselves up or help them turn. The resident changes positions in a chair with push-ups and with shifting weight from one side to the other. The resident has a wheelchair that is usually friendly, enabling him or her to be more independent. Prevent shear or friction injury through proper positioning, prevent sliding, and proper lifting. Help the resident use assistive devices that enable good alignment and positioning. Supports, stabilizers, splints, orthotics, and braces are names of devices used to help maintain alignment and position of function. Assist the resident to reposition at time intervals that keep the skin healthy over bony prominences. Avoid massaging the tissue directly over the bony prominences. Use pressure reducing surfaces and padding devices in addition to helping the resident change position. There are different types of mattresses out there that help reduce the pressure. There's also different types of overlays for mattresses that we can use to help reduce pressure. Provide routine skincare in folds and creases. Provide skincare promptly after incontinence. Keep bedding dry and free from wrinkles. Encourage the resident's participation in a toileting assistance program. And encourage the resident to have good nutrition and adequate fluid intake. Range of motion. Range of motion refers to moving joints through their full motion. Moving helps prevent joint contractures and muscle atrophy, again, which is muscle wasting, and stimulate circulation. The care plan or protocol will direct how frequently to assist in the range of motion exercises. Although encouraging the resident to move limbs and body as much as possible during the ADLs is not formally counted as range of motion, the movement remains beneficial. So just because they're moving their extremities, moving the joints during ADLs, that is not formally counted as range of motion exercises. Family members may be taught to assist the resident with range of motion. Active versus passive range of motion. The active range of motion, or AROM, occurs when the resident, they can move their own joints. When you have to assist the resident to move the joints, but the resident performs the activity, the term is active assisted range of motion, or AAROM. Passive range of motion occurs when the nursing staff or therapist moves the resident's joints, providing the exercise. For example, PROM would be used when a resident has a paralyzed extremity. So PROM is where they cannot help out at all. Active range of motion is where they do the actions themselves, or they might just need a little bit of help stabilizing to do the exercise. That would be the active assisted range of motion. Safety, exercise a joint to the point of discomfort or to the point of a firm stretch. Never force a joint to move. Check with the nurse when the resident experiences pain during the range of motion. There is a wound or skin tear on a joint to be exercised, or the resident is combative when you attempt range of motion. Now, we went through range of motion exercises in the lab, so you should be familiar with the different types of exercises and which joints to exercise. So we have abduction, which is moving the joint away from the body. Adduction is moving it towards the body. Flexion is flexing that muscle, and extension is extending the muscle. Range of motion exercises. The neck is only active range of motion. Only the resident does that. If they cannot do the active range of motion, we do not do that for them. But we do the shoulder, the elbow, the wrist, the fingers, the hip, the knee, the ankles, and the toes, just like we did in lab.